My research project is on Pierre-Robin sequence in orthodontics. Pierre-Robin is called a sequence because it's a lot of different things that can cause it. It's not normally caused by one thing. And the first time it was described was in 1923 when Pierre-Robin described patients with mandibular micrognathia and glossoptosis, which led to the upper airway obstruction with Pierre-Robin sequence. And so what basically happens is when a child is born, pressure is put on the mandible is not able to grow, and you're going to have a deficient mandibular size. And because of that, the tongue is going to be placed backward, and the tongue is not going to be able to be put up to the palate. And because of that, you'll get a cleft palate, and usually what's common is a U-shaped cleft palate, which is different than the normal cleft patients. And so you're going to see that small mandible that is positioned posteriorly. The tongue is going to be positioned posteriorly, and due to that fact, it will obstruct the airway. Now, looking at the methods that went into this research, there was a lot of different strategies that were used and employed. We looked at PubMed, Medline, Web of Science, looking at Pierre-Robin syndrome, Pierre-Robin sequence with dental or orthodont, looking at those phrases as well with just orthodontics and orthodontic treatment, mandibular development, airway obstruction, and these terms were used through these databases in English from 1923 to 2021. The references were reviewed by the PI as well, and the literature search is always going on because there's always current data being evaluated. And when looking at the results, we saw that these RS patients that have this micrognathia, the tongue that is posteriorly positioned, causing the upper airway obstruction, you're going to have difficulties that are going to be very concerning for this and for the growth of the mandible in these patients. But in most of these infants, these issues can be addressed by having the infant placed in a prone position and then just waiting for the mandible to grow and to catch up with the maxilla, and usually should be fine. But a lot of times you'll see that this traditional approach will open up the airway as the tongue and jaw move forward. But if in that case that this approach does fail, the next step would be to take a conservative treatment or surgical plan. And currently there is no surgical approach that outweighs the other. It is rather dependent on the patient's specific needs. And the role of the orthodontist concerns both the patient's dental and skeletal development. They want to look at the transversely narrow maxilla, the cleft, the mandibular retrognathia, and then there's going to be a vertical growth tendency. So these patients are going to have obviously a class 2 malocclusion, they're going to have severe crowding, and tooth bud injury can occur when mandibular distraction occurs. It's very common for these patients to be treated in a two-phase orthodontic sequence, maybe even more than two phases, multiple phases, where the first time they're coming in, you're looking for all that the primary dentition, and then looking at seeing how the permanent dentition comes in. So phase 1 would be to reduce the severity of malocclusion, fix the crowding or any asymmetry of the arches. After phase 1, then you want to look at the anterior posterior discrepancy, class 2 correctors to fix that skeletal discrepancy, such as elastics or forces. And then what can be the last resort as well can be mandibular distraction, osteogenesis, which is a surgical treatment strategy, but it is more invasive, and it's pretty recent. It's still new, and this relies on the biological concept that when bones are pulled apart, new bone will fill in between that space, and it uses either an internal or external device. Internal device carries a risk. The externals causes scarring, internals inside, externals outside, and more noticeable obviously as well. And with mandibular distraction osteogenesis, there is going to be an overcorrection as well of the mandible, and because there's going to be some relapse in the mandibular length, and a lot of times these patients, because they have cleft palate, the palatal surgery to close the cleft can be done between 10 to 12 months. And that's it for the results, and we're still looking to do the conclusion, and that is next up on the list.